Sorry, go time. Okay, so this is what I don't know if you guys sent me emails or posted on the Canvas page in the last few hours about the teams. Did anybody send me an email recently, like in the last this morning, about the teams who you want to be with or something? I'll take that as a no. So this is how I structured it. The black names are people who sent me things, and then the gray names I either haven't heard from or they said like wherever is fine. And so I tried to shuffle a little bit here and there. On the 5-person teams, like Gurdeep isn't going to be present, so that is mostly a 4-person team. So I tried to shuffle it around that way. Ish. Do you have objections? If you have some sort of, I was hoping I was going to be on, whatever, just whatever. I can move things around. So you remember this stuff. You remember Herodotus, Hippocrates, Galen, the Greeks. You remember the barber surgeons, the Islamic Golden Age, all that historical stuff. We'll talk about it a little bit today. There will be a little bit of commentary. Here's where we come from when we're talking about things like diabetes. You remember Pichicola's paper about Rosti, that case, and the potential consequences of getting it wrong. In most things in life, if you get it wrong, it's like a missed free throw. Who cares? You like just inbound the ball again or whatever one does. You know, the consequences aren't severe when you're working with bodies, and especially making those bodies exert themselves. The consequences are pretty dire. And if you get it wrong, if you get it wrong and it's your own body, you'll be paying for it for your lifetime, maybe potentially, or with your lifetime. If you get it wrong and you're a clinician, you're a practitioner, you're a PT, you're a personal trainer, you're an occupational therapist, you're something like that, and you get it wrong, your patient or your client is potentially dead or wounded, and the worst thing that happens to you is a lawsuit for sleeping problems or something. So remember these, and on Friday, there's all 9 of them here. You can't read a word of what it says, but you have the PDF. So those 9 signs and symptoms, you know, in the heart and the breathing, stuff like that, things to look for. And then these 6 classifications, you can be stratified in 6 ways based on how you score in those signs and symptoms. And then also remember this one, because on Friday, when you're going to be doing your case studies, you'll be doing everyone else's case studies, trying to solve their riddles. Part of it is these 9. You have to figure out if there are signs and symptoms in them. And then part of it is these 8 or however many, 1, 2, 3, 4, 5, 6, 7, 8. We'll call it 9. So you have to do both with the case studies. You already have it. You have the PDF of that stuff. And make your case studies a little bit more comprehensive. Let's do a couple just to start off the day. And then we'll talk about CVD. We'll talk about diabetes. And we'll talk about cancer, briefly cancer. So in exactly 500 days, Caleb will celebrate his 40th birthday after just 100 more days from that day. He has worked on Pygmy cattle ranch in Central Oregon since his 18th birthday. Hard, sweaty labor. He has to hoist hay, and sometimes it's wet and heavy. He gets at least 10,000 steps in every day, just rambling around the farm. He doesn't know what his blood pressure is. He did get a lipid panel a year ago. Total cholesterol 206, HDL 77, LDL is 122. His father continued to work on the ranch until he was 80. Then he and his mostly healthy wife moved to Arizona. Caleb's BMI is 31.7. Doesn't know his fasting blood sugar, and he quit smoking approximately 3 months ago. He also became a father this year, a son. He named his son Caleb Sr. How many risk factors? Let's start with, does he have signs and symptoms of disease? No. So he's clear on those initial 9. So that stratification of, does he have a diagnosis of something? Renal, does he have a diagnosis of cardiovascular or metabolic? Does he have diabetes or coronary heart disease, something like that? No, and no signs and symptoms. How many risk factors does he have? Smoking, he just stopped recently, so that counts. Smoking counts. I think it's 6 months. I think is what it is. You have to stop smoking. Let's see what it says. Smoking. 6 months. If you quit within the previous 6 months. He's quit within the previous 3, so smoking counts, that's one.
-1 for HDL.
-1 for HDL. So if you're just looking at his total cholesterol, 206, that's the cutoff. But that's 122, that's not over 130, and his HDLs are really high. So that's -1. BMI, that counts. That's over 30. 30.000000 or up.
48.
Yeah, something like that. I don't know. He's probably up over 45. I didn't do the math, but in 600 days, he'll celebrate his 48th.
Oh,
Yeah, he's over 45.
Not sedentary.
He's not sedentary. Now, here's where it gets a little bit tricky. To be on the safe side, he doesn't know his fasting blood sugar, but he's over 45 and he's obese. So things like fasting blood sugar and blood pressure, to be on the cautious side, I would count those. ACSM has exact stipulations about how to count unknowns, which situations, which circumstances call for the counting of unknowns. But if somebody's obese and over the age of, risk factor, good situation in which counting those as risk factors would be prudent. It would be cautious. It would be wise to do so. So 1, 2, 3, 4, 5, 4. 4 if we're being super conservative and cautious, right? 2 if we're just like, well, we don't know those, variables. We have 2 documented risk factors. 4 if we're being really cautious. Okay, Freddy Krueger was born in February 1942. From 1975 to 1977, going by the name of the Springwood Slasher, he got a lot of exercise chopping up little children with his hand and glove scissors. During the last dozen years, Freddy has stopped doing that, so he hasn't been very physically active. He took up smoking and started experiencing chest pain, so he went to a doctor, just panic attacks. But during his appointment, he got his cholesterol and BP taken. During his health history, he revealed that he doesn't know his biological relatives on his father's side. Here are his digits and a list of that stuff. All right, what are his risk factors? Well, first, are there signs and symptoms of a disease or a diagnosis? So for the blood pressure there, yeah, that's hypertensive. But yeah, so the chest pain, just panic attacks. Okay, so that's something we'll just watch. Maybe we'll get you on, I don't know, some sort of anti-anxiety or something and see if that helps. But it's possible there's nothing structurally wrong. If there's a little bit of chest pain, all right, let's look and see if there's coronary artery disease. Let's see, we'll talk about that today. Let's see if there's insufficient blood getting to the heart muscle itself. No, they didn't find that. It's just this sort of psychological thing. Let's be very careful with that. But this wouldn't count as a diagnosis of high risk. It's something to be extraordinarily mindful of, but not prohibitive about.
Smoking and he stopped being physically active.
Okay, so physical activity, wherever that is, physical activity and smoking.
The
Next sentence. And his age, right? He's born in 1942. And his BP. His LDL's 160. HDL is super low too. Yeah, this is his triglyceride problem is bad, but we're just counting it as one risk factor between the two of those. So we'll just fuse those two. Just like his blood pressure, both of those numbers would count as a risk, but it's a single risk. Now, when you have high LDLs and low HDLs, we'll talk about that today, how that gets even worse, how that compounds risk. And even worse, when you start to see blood pressure elevated and HDL, LDL profile being poorer, that compounds the risk. It's not 1 + 1 is 2. It's 1 + 1 is 5. I don't know that math here, but the immune system and blood pressure and lipids, they all play part of a role together in predicting cardiovascular disease. We don't have an immune profile though. Most people don't know their white count. most people don't have a profile of what macrophages and leukocytes and whatever. Is that it? Is that everything? So waist circumference 99, that's close to the 102 cutoff. So something you could do if you're trying to trick people and say, look, BMI is only 27, but waist circumference is 102.2 or something, because waist circumference is another cutoff, 88 for women, 102 for guys. But then you could say family history, right? We're being cautious, doesn't know his dad. This is the side of the family. So potentially there were complications on his dad's side of the family that we don't know about. So be cautious and read more into some of the sentences than they provide. Everybody likes to conceal information. When you're talking to people, not everything gets revealed. And you have to deduce some truths out of what people are saying, especially with health, where people tend to hold their cards, not just close to their chest, but like in their aorta is where their cards are. So this is what we were talking about the other day. This was one of the tests in stress biz. We don't have to go through everything, but this is just an example of what you could do for your team for the competition. In the year 2025, Pacific will host a Hogwarts versus Middle-earth fight to the death cage match. It will take place on the lawn just outside of this classroom. Dumbledore has been summoned to represent Hogwarts. Gandalf will be representing Middle-earth. Do you guys know Harry Potter and Lord of the Rings? No. Although the battle will end in death, it seems likely the death will come by way of cardiovascular event rather than lethal magicianship. Your team get to place a bet. Your team will place a bet on who you think will win. Consider the following information before making your decision. Gandalf was born before the shaping of Arda, while Albus was born in 1881. According to the History of the Hobbit, Mr. Baggins, page 49, Gandalf is only 5'6". He's huge in the movie. But this is like, look it up. He's only 5'6". Dumbledore is nearly a foot taller. In the year 2020, they each weigh, they each weigh about 200 pounds. Gandalf doesn't know his HDLs and LDLs, but takes medication for his cholesterol and knows that his total value is somewhere in the 160 zone. Gandalf's BP is 124/82 and fasting blood sugar is in the 80s. He doesn't smoke often, but when he does, he can shake boats out of his smoke rings. Dumbledore casts a spell on his blood pressure. The magic works exactly like ACE inhibitors, so his blood pressure is okay. His total cholesterol is 220, fasting blood sugar is 96. Because Gandalf hails from epic fantasy, he does a ton of walking. Epic fantasy is if you walk, all story long. And Dumbledore now travels exclusively by apparition spells. Neither magician has diagnosed disease, and neither shows signs or symptoms of disease. The Dumbledore family has suffered lots of health and death problems, mostly cardiovascular in nature. Gandalf, being a wizard of Middle-earth, has no such problems. So there's a lot of sort of trickery here. Because one of the things is, if your cholesterol is fine, but you're taking a drug, that counts. It still counts. People have done research on statins and found, yes, we improve the cholesterol, our lipid panel, and the incidence of adverse cardiovascular outcomes is unchanged. Now, there's a lot that can go into that explanation, but just because someone's taking a drug, you don't immediately wipe that off of the slate. You still count that as a risk factor, even though it's okay. So if somebody's blood pressure or cholesterol is off, and over here, you have Dumbledore cast a spell on his blood pressure, works just like ACE inhibitors, you would count that. So that's the sort of trickery that you want to put upon your opposing teams. And some of the stuff is unclear. The Dumbledore family has suffered lots of health and death problems. It doesn't explain when that was. Conservative, you would want to count that one. And in answering your Friday exercise, just what I would say is explain things, right? Be cautious, explain things, answer everything, and then explain how you got your answer. It's like when you're a little kid and you're in math, like show your work, but the number is right, isn't it? Show your work. You can do the same thing here, and it sort of shields you against criticism because your work is probably accurate. The way you went about it is probably accurate. What you arrived on may be a little bit different, but that isn't quite as important as showing a sense of logic or thinking. Okay, so we'll talk about CVD, but in the risk factors, blood pressure and lipids, right? Cholesterol, lipids, HDLs, LDLs, stuff like that. These are the two risk factors that everyone pays attention to. They aren't the only risk factors, right? But for cardiovascular episodes, these are the two important ones, blood pressure and lipids. And so from Circulation 2021, right, this is a brand new publication from the American Heart Association. The data aren't brand new, but it takes a long time to export and clean. Nathaniel knows this, export and clean, and write up a manuscript, analyze it, write up a manuscript, and publish and go through the. So it takes time. So this is from 2015 and 2018 data, but this just came out, right? This is the most recent data we have. And in the US, we have NHANES, it's a huge epidemiological database. The prevalence of cardiovascular disease, which constitutes coronary heart disease, heart failure, stroke, hypertension. Hypertension is counted in here. In adults age 20 and over is about half the population. For American adults, people age 20 and up, it's about half of the population. Now, most of that is hypertension. Again, blood pressure, right? Blood pressure, that stuff, so many people have hypertension. So if you exclude that, it's under 10%. But 10% is still a lot. 1 out of every 10 people over the age of 20 has coronary heart disease, heart failure, stroke. These are pretty severe. It's 1 out of 10. Now the heart is just a pump, right? It's just a pump, and it's a fascinating one, which is why you go back to the 1500s, and that's all anybody was studying is heart, circulation, circulation, circulation. And what's the liver do? It's something with the heart. It's making the blood. Every organ. It's like something about the heart. And circulation is what everybody cared about for the longest time. Now, if you think about what the heart does, it has to pump, just like if you're pumping up a bike tire. You guys have pumped up a bike tire before, like one of these little handheld ones. Early on, it's super easy because the tire's flat. And as long as it's like sealed and it's a closed system, like your cardiovascular system, it's a closed system. It's not an open system, it's closed, it circulates. The more air you put in the tire, or the more blood, the more fluid you put in your vasculature, the higher the pressure is. That PSI goes up. And with each additional pump, as you get more and more air in there, that PSI goes up, it's harder and harder to pump. And so what happens is that heart squeezes harder, squeezes harder, squeezes harder, works more and more and more. Now there's a lot of immediate resolutions, right? And you can just do a diuretic and lose some of your blood, lose fluid, just pee out essentially the water in your blood. You could do that. Furosemide, something like that. If anybody's ever taken furosemide, you have never peed so much. It's as though you just drank gallons of water, but you didn't. But that's what it feels like when you take it. So a diuretic, you're going to start flushing out the system, and then suddenly you can pump easier. But the more pressure in that tire, the more pressure in your vasculature, the harder the heart has to pump to get it out of there. And it's not just the matter of the heart. The heart is pissed at you if it has to pump that hard all the time. But you can also get an aneurysm, right? If the pressure is really extreme in your vasculature, if there's a weak spot in those vessels, this is going to happen, right? If there's a weak spot in those vessels and there's an acute increase in pressure, you will risk an aneurysm. You're not going to have, but you will risk an aneurysm. So blood pressure is acutely very threatening, but chronically it's very threatening in a different way. So the acute effect of high blood pressure is you can have an aneurysm, you can have this cardiovascular event that's very immediate. But getting into the chronic part, skeletal muscle, everything in the periphery, it doesn't really take that much oxygen out of the blood. The blood goes by, it takes a little. The way like a dog eats and the way a cat eats? You put cat food in the dish and the cat comes by and eats like 3 pieces and then leaves. Our neighborhood cat does that. Eats like 3 pieces and leaves, and then like the ants show up. Just Come on, pig pan. Like, eat the rest of it so I don't have to worry about ants all the time. A dog, though, if you put out 50 pounds of food for a dog, the dog will eat itself to death. Right? The heart is more like a dog. It's ravenous for the oxygen that goes through. Now, you don't need to know these exact percentages or anything like that. Study by study, you're seeing slightly different percentages. But the theme you have to know, which is the heart takes an awful lot of the oxygen that passes through in the blood that passes through. In the periphery, it doesn't take much, right? That's just a cat. It's a well-fed cat that's going to eat like a bite of it. All right, I'll eat 25% of whatever's in that dish and just, you can have the rest. That's in the periphery. So during exercise, right, that's at rest. During exercise, you start moving, you start lifting, you start doing whatever. And one solution is just to take more oxygen out of the blood that's already there. There's already supply, and let's just take more. That's what you do in the periphery. Can't really do that in the heart, though, because you've already eaten everything that was in the dish. And what we see in the heart, what we have to do, those coronary arteries, we have to dilate them. We have to dilate those coronary arteries, the arteries supplying the heart muscle. And somebody who exercises has a much greater capacity to dilate the coronary arteries. This is just one study. There's 1,000 studies that say this. I just needed one for the screen. Twofold increase. Who cares what the number is? An exerciser, an aerobic exerciser, can dilate those coronary arteries, supplying more blood to the heart, because they can't just take more oxygen out of the blood that's there. They need more blood to come. And if you're an exerciser, you get way more dilation. Now, if you have atherosclerosis, right? If you have plaque deposited in your coronary arteries, way less ability to dilate. And again, tons of articles have evaluated this, and it depends on the degree of atherosclerosis, right? It depends how severe this is. It depends on the exercise. It depends on the situation. It depends on the person. It depends on the age. It depends on a lot of things. But there's a considerable deficit in the ability to dilate. So you start exercising. Ross died. Remember Pig's case, Ross died. He starts exercising and he says, I'm having chest pain. It's uncomfortable. I'm having chest pain. It's in my armpits, right? So it's in my neck and back and chin and armpits. And but it's mostly, I'm just like, I can't catch my breath. He's going to have coronary artery disease, right? He can't dilate those arteries and he's exerting himself. So the heart muscle is beating. It has to, otherwise, you die. And it has to beat, and the heart isn't getting enough blood because those vessels can't dilate. Now, the more in shape you get, the better it can dilate. Even if you have atherosclerosis, there is evidence that exercise really improves your condition. But you can't just leap into it, right? Otherwise, you get the Ross die situation where here's like a normal person, there's Ross die. Let's just go. Adverse events, right? He ends up having surgery. So now where blood pressure and cholesterol, the lipids, where, dyslipidemia, where these link up, HDLs and LDLs are already really talked about. But if you have hypertension and a bad lipid panel, that's where things start to get a little bit compounded. And again, I could put up 100 different articles on this. Here's a couple that talk about your white count, talk about the immune profile. If you just have high blood pressure, so some people get panicky. They read something about high blood pressure and the risk of hypertension. American Heart Association puts out a statement or something, and people panic a little bit. Oh, my blood pressure is high. Yeah, but what's your immune system like? What's your lipid panel like? If you have isolated systolic hypertension or something like that, okay, the risk is like nothing. I mean, if it's really elevated, that's something. But if that's all you have, it's not really a big risk. You have to get the immune system involved. You have to have the lipids there. You have to have the HDL profile off. And when all of those are present, now things get risky. All right, so this is the blood vessel. And the intima, right, the inside right here, the intima, this is where you're going to get your plaque deposited. The plaque is going to be deposited in the intima. So the steps of doing this, lipoproteins, right? Cholesterol is not fat, it's like this waxy thing, but it's inside of proteins. Your lipids, LDLs, low density lipo or lipoproteins, HDLs, high density. These are proteins, and inside of them is this waxy substance, and it gets delivered to the liver, and it gets delivered there badly by LDLs. They just crash all the time. LDLs are like, I don't know, who's like horrible drivers? Without saying something like sexist or racist or whatever. You can be an ageist. That's fine for now. For today, in today's culture, I think it's okay a little bit to sort of be an ageist. Who's like a bad driving? Okay, teenagers. Okay, so LDLs are teenagers. Okay, they're like, I don't know, they're on their phone or whatever, and they crash all the time, and they're just left on the side of the road. Their car is just like, banged up on the side of the road. That's LDLs. Who's a really good driver? Like truck drivers when they've slept. If a truck driver has gotten some sleep in the last couple of days, those are the HDLs. That load is going to get where it's supposed to. HDLs, they will carry that waxy trailer exactly where they're supposed to go. They're not going to get in a wreck. They'll deliver it. It's not going to wind up on the side of the road. LDLs, those are the teenagers. So if you have elevated blood pressure, you're going to increase the deposition of LDLs, not HDLs, but LDLs in the intima. High fat diets, high sodium diets, those raise blood pressure. Not in everybody, right? There are responders and non-responders. But if you check your blood pressure on occasion, and just see where your blood pressure is, if you're hypertensive, check how much sodium you're eating. Check how much fat's in the diet. So like, there's enough evidence that those things are routinely increasing, elevating people's blood pressure. Now, some people have hypotension and need to increase their blood pressure. Okay, put some more salt in your mouth. But knowing where you are is always helpful. So as long as those LDLs, right, as long as those teenagers, if they don't get stuck on the side of the highway, if they don't get stuck in the intima, if they don't get deposited there, or they can be, deposited, but if they don't get permanently stuck there, they can leave. That's okay. They sort of like, they're moving along, they're going, and they sort of get like pushed off to the side of the road. And I don't know, all they do is like replace their tire or something, and then they're fine, and they keep going. That's one thing, right? So if you ask an ER doc, like all the craziest things they've seen, like up rectums or something, like, yeah, it comes out though. It's not there forever. A plastic giraffe, a toy soldier, and a Barbie doll. I think there's a dog eating all the kids' toys. But it's not necessary that an LDL gets stuck there, but it can if it gets modified, if it gets oxidized, glycation or oxidation. If that stuff happens, then it becomes a very sticky, oxidized cholesterol. Very sticky. That's not going anywhere. That's like the engine's trash now, and it's permanently on the side of the road. It's gonna have those orange cop stickers on it for like the next 6 weeks. So if it gets oxidized, oxidation, loss of electrons. So they could be mobilized, but they're not going to be mobilized. And you've done this before, right? If you've touched like cholesterol, whether it's like butter, from meat or from butter or something like some dairy, and fat that's from, an avocado, fat that's from, some vegetable source, that's not the same thing. It's oxidized cholesterol. This is different. I mean, this is like, you have to wash 15 times to get your hands clean stuff. So this, oxidized LDLs, those get stuck. Oxidative stress, right? So some free radicals and the products that are found within those modified LDLs, they send out a chemotactic signal. Chemotaxis means chemical direction. Toucan Sam, like the Fruit Loops bird or whatever, which follow your nose, and then he goes like and finds where the Fruit Loops are. That's essentially chemotaxis. It's a chemical signal that tells the immune system how to behave. Oh, send stuff here, right? Or don't send stuff here. We are very averse to that thing. Don't send that thing here.
The LDLs are really sensitive.
Yeah. So the modified lipoproteins are sending out, in part, sending out that chemotactic signal. So let's get an immune response here. You send up a flare gun, and let's get an immune response to come in here. Phagocytic cells, when I say that, what comes to mind? Yeah, macrophages, stuff that eats stuff. Phagocytic, that's a digestive term. So these phagocytic cells, macrophages, they come in response to the chemokines, they're summoned, and they send out their own signals. They really exaggerate this response, this chemotactic signaling, chemical signaling. The macrophages take up, they digest these LDLs, these modified LDLs. They're coming to clean up the trash. Macrophages come in to clean up trash. They engulf things with the purpose of trash removal, not with the purpose of, I'm going to bag up all your trash and leave it here. That's not what they're supposed to do. What a macrophage is supposed to do is bag it up and haul it out. But that doesn't happen here. So they engulf it. We have a white blood cell with oxidized LDL inside of it, and they form what's called foam cells. More chemotactic signaling comes. Right now, we're continuing to summon the troops here, but we have these foam cells, these macrophages with an oxidized LDL inside of it. Now, the smooth muscle, mitogenesis, starts to divide, right? And some migrates into the area and encapsulates it. So now we have this sort of protective shell, this sort of tissue protective shell over the plaque, right? The smooth muscle comes and sort of engulfs it. Calcification of that can occur. Later steps, you can get calcification of that shell around it. This is basically what it looks like. So here's the blood vessel. On the inside, you have intima. Here's where those oxidized LDLs were deposited. Where the LDLs were deposited and where they were oxidized and got all sticky. Had that immune response in here. The macrophages engulfed them, became foam cells. Now we have these current sort of permanent residents, and then the smooth muscle encapsulates it. If you get a crack in that plaque, this is your plaque. If you crack the plaque, you leak. You bleed, you leak, and you have to clot. Right? You crack the plaque, you leak, you clot. If that clot stays put, okay, and this is, I don't know, maybe 3/4 or something like that, the majority of these like adverse events. So think about a hose out in the sunshine, right? It's a hose in California for like 11 months out of the year. The sun's beating down on it. It becomes less pliable. Right, the hose can't bend very well without cracking, right? It just gets all dried out. And that's what, if you have an excess of LDLs and high blood pressure, that's the sun baking the hose. And so what the hose is worried about is this, a crack in the plaque, right? It starts leaking. The thrombosis, this is the formation of a clot. Really, it's fibrin-fibronectin cross-linking. We can talk about that later. But fibrin and fibronectin cross-link, and then platelets get gunked up in there, so you get this clot. If that clot breaks and enters circulation, you have an embolus. The clot enters circulation, you have an embolus. It's sailing waiting to clog up wherever it bottlenecks, right? Wherever the road gets narrow enough, it's going to plug that thing up. So that's an embolism, is the embolus clogs, it lands, it docks, it blocks. Okay. So coronary artery disease. Coronary, remember crown, corona has a little crown logo. Your coronary arteries are crowning the heart. The heart is a muscle. That muscle needs an oxygen supply. It's not going to pump for free. It needs oxygen, right? There's a metabolic price tag to doing that. The coronary arteries provide it. If you have all of that plaque there, you're going to wind up with an elevated risk of myocardial infarction, a heart attack. So that's coronary artery disease. And early stages, early signs, those symptoms of coronary artery disease would be that pain in the chest. What Rostai experienced, that pain in the chest. What other people experience now, it could be indigestion. A lot of people, they get chest pain and the panic attack that follows, like, oh my God, I'm having a heart attack. Well, you just ate like a fatty meal and reclined. I don't think that's a heart attack. I think that's just acid reflux. And yes, it feels like the exact same to you right now. But during exercise, right, that constriction, that tightness, pain in the chest, that's evident, it's indicative of cardiovascular disease. Now, what do we do about it? Right, exercise really is the best solution. Drugs work pretty well for the heart. Drugs actually work pretty well. The pharmaceutical industry has developed some good ones. In particular, statins are really effective. Simvastatin, atorvastatin, anything statin that ends in a statin, those are really effective for lowering cholesterol. There are also blood pressure medications work well too. But exercise has an enormous advantage in both inoculating us against disease, the onset of disease and the advent of cardiovascular events, as well as providing a kind of sort of curative. It doesn't just solve everything, but mitigating some of the effect, mitigating some of the damage once it does build up. So just put this article. This article is, if you go, and I got clinicalphys.com. If you just type that in, as opposed to that, like courtneyjohnson.com/clinicalphys.html, like nobody's going to remember that. Clinicalphys.com is easier to remember. This is already up there. So there's a little link, and it's a zip file with 5 articles in it, with 5 PDFs. This is one of them, in case you want to read some of this. But exercise, cardiovascular disease, massive killer. Now, we think it's a bigger killer than it is because a few studies have come out recently where they found what's the cause of death in these patients, and nobody ever admits, I fucked up. Nobody ever says that. The doctor's like, my mistake. They're not going to say that, right? And so what's the cause of death whenever a doctor messes up? Cardiovascular disease, heart failure. There's something there because the person eventually stopped pumping blood. Now you could say the cause of every single death ever was heart failure. When I first moved to Connecticut, I worked with HIV patients. And I had been to Cameroon and watched people dying of AIDS. And I remember going, it was a medical mission. I was there for a month on a medical mission in Cameroon. And people, I mean, dying of AIDS. Not like, you know, in the US where people are sort of symptomatic, but they're on antiretrovirals. I mean, dying. There's no access to medicine, AIDS at its worst. And I remember coming back to the US, going to my PhD, and people who have never stamped a passport. Oh, you don't die of AIDS. You die of complications from AIDS. It's such a cliche. You'll hear it. If you go into work in a field, people will say stuff about whatever the symptoms, whatever the disease is. Oh, you don't die of that. You die of complications from it. Okay, if we're being honest, that's the same thing as saying nobody has ever died from a bullet. You die of complications from that bullet's course, from its path through your skull and through your heart. Nobody has ever died of a bullet. Likewise, nobody has ever died of AIDS. It just sounds like you're such a buffoon when not you all, but when people say that. And so nobody ever wants to admit, though, that they're wrong. So you say cardiovascular disease. What kills every age patient? Oh, the heart stops. Okay, but that's not really what killed them, right? Medical malpractice, really high cause of death, and it was always coded as heart failure. And so people thought cardiovascular disease was a much bigger killer than it actually is. It's still number one, but it's not that big of number one. Right, so look at, there's the biggest study, the one that was really impressive came out of Johns Hopkins. This isn't like a weird analysis by somebody who hates the medical system. This is Johns Hopkins Hospital. And so they're coding all medical malpractice as heart disease, but even when you correct for that, even when you correct for it, heart disease still is the number one killer. It's just not as bold as people thought it was. But exercise, in particular, aerobic or cardiovascular exercise, metabolic aerobic cardiovascular, long duration, moderate intensity exercise has a lot of positive effects that will help ward those things off. In the article, it explains all the mechanisms. There are sections in the article dedicated to these 5 categories, right? The lipids, we know all about what the lipids, HDLs, LDLs, and the atherosclerosis they develop. Insulin sensitivity, we're going to talk about that in just a minute. Insulin sensitivity is to diabetes. Blood pressure, you know how blood pressure works. Cardiac adaptations itself, the heart adaptations, and then the blood and vasculature. What happens to the blood itself, you know, whether it's oxygen carrying capacity or it's the vascular channels, the networks. So it goes into detail of all that stuff. But to me, that isn't as interesting as understanding the pathophysiology, the genesis of how these things arise, because you already know the answer. If you know how they arise, you know they don't arise. All the stuff we just talked about, that gets reversed. Like, okay, well, HDLs go up, LDLs go down. Okay, we just talked about what that means, right? How those things work. And then, but it does get something that's a little bit more interesting is 2 things. One, there is a too much. There's a too much here. This is from the same article. Marathon runners, not like you've gone and done it once, but if you do marathon after marathon after marathon, that puts you at elevated cardiovascular stress. You might as well just be like, you know, sedentary and obese. If you're a continuous marathon runner, there is a too much where the heart doesn't respond favorably to additional exercise. It's this, that applies to everything. You know, over here, that's going to associate with cardiovascular risk. Down here, that's cardiovascular risk. Everything is Goldilocks. Same with the heart. But here's where it gets even more interesting. This is from Claude Bouchard, super famous exercise geneticist looking at exercise. It's a French guy. This is one of his studies from 2012, and some people respond poorly to exercise. Most people, you say go exercise and you reduce your systolic blood pressure by 4 to 9 millimeters of mercury. You know, we have these blanket statements about the value of exercise, the response of a body to exercise. But those are means. Not one person in this room is a mean. We hover around the mean. Each of us is probably pretty close to the mean. But when you're looking at the adverse responses, you know, blacks versus whites, all these different studies, what percentage of people had an adverse response to exercise? Meaning your blood pressure is elevated, your HDLs go down, stuff like that. Oh, a fifth, right? 2/5 there, you know, maybe a quarter, a third. That's a lot of people having an adverse response to exercise. How many people had 2 adverse responses? Yeah, 4 or 5%, 3, 5, something like that percent. So here's what it looks like. Plasma fasting insulin. Most people, each one of these, there's like 714 or something like that people in these graphs. Each little point here is a different person. So this person lowered their fasting plasma insulin by however much, I don't know, 20, whatever. Over here, all of these people were worse. Exercise made them worse. exercise put them at risk of diabetes if they didn't already have it. Some people, over here is just sort of no effect. All these people here is like no effect. Most people respond favorably to exercise. This red section, some people respond terribly to exercise, and it's a good thing to know. Like, well, you know, I'm at risk of diabetes. Okay, let's get you exercising. You better monitor that, because what if they're one of these people? What if they're one of like the fifth of people who have an adverse response to exercise? Now you're worsening their diabetes with a prescription that you think should work. HDLs. Most people are increasing HDLs, right? And you see that. Most people with exercise, go do some aerobic exercise for a while. Let's see what happens to your lipids. Some people get a terrible reduction in their HDLs by doing the exact same exercise that benefits everybody else. Go run on a treadmill, get on a recumbent bike, do whatever, and their lipid panel suffers, right? Plasma triglycerides. Some people get a huge spike in triglycerides with exercise. Systolic blood pressure. This is the one where people say 4 to 9. That is the mean of all people. If you get 50,000 people and have them all exercise, you'll see a mean reduction in blood pressure, and systolic blood pressure. Some people get a terrible adverse response where blood pressure goes way up. So exercise is really helpful for most people. For some people, they shouldn't be doing it. Now, also for other reasons, Van Ness studies myalgic encephalomyelitis or chronic fatigue syndrome. Exercise is horrible for them too. You want a daily dose of physical activity, but exercise can be rough. So the only study that I put in the file is this. This is a zip file. So this one, it covers all of this stuff, all of the mechanisms. It's the same. It's just the opposite of what we were talking about pathogenesis. So now obesity, let's transfer into diabetes. Obesity is unsurprisingly elevated. Year after year after year, decade after decade, we see this trend increasing. So I went on the CDC this morning, this website this morning, and here's the states they put up. It's not like up to date for today, but all of these red states right here, right in that sort of belt that you would think they would live, is over 35% obesity. And New Jersey has insufficient data. Like everywhere in the world has data, except New Jersey has no idea, how many people are obese for some reason. So also, it's accessible from the CDC website, but this is the data from February 2020. You can get this PDF also on that same website. This is the percentage of people who are obese in the US among adults aged 20 and over. If we're gonna look at the total in the different age groups, it's like 40%. That's high. We're getting prevalence of obesity among adults aged 20 and over in the US. Yeah, we're getting pretty high there. Now, obesity, if you're going to look at the relationship between obesity and diabetes, this is just a study among women, but women with a body mass index of 30, that's obese, have a 28-fold increase in the risk of developing diabetes. 28 times the likelihood. Now, sometimes, I've read this study about bite wing x-rays at the dentist, and you're going to increase the odds of this particular cancer 100-fold. What are the baseline odds? 1 in a billion. Okay, give me the bite wing. Right, who cares? Like like one person's going to get it. This is not interesting. Diabetes, a lot of people do get it, right? If you have a 28-fold increase in the odds of developing diabetes by having a BMI of 30 or higher, that's worth acknowledging. Now, get that BMI up to 35, right? Get into that morbidity section, and the risk of diabetes is almost 100-fold increased. So obesity and diabetes have a really tight link, those two. Now, what's the cause? Nobody has any idea, right? We all have an answer. I have an answer, you have an answer, everyone has an answer of what's causing the obesity epidemic. What's the culprits? And whether it's sedentary lifestyles, it's excess of calories, of macros, right? It could be stress, it could be poor sleep. There's any number of explanations. And to a degree, all of them are sort of uninteresting. But on the subject of diabetes, there are some don't take this as gospel. This is one analysis. It's a compelling one, and this is the only one to do it. But U.S. obesity as a delayed effect of excess sugar consumption. How much sugar do you need every day? Net carbohydrates and sugar, and how much of this goes in your mouth every day? And the analyses are strong. This is a strong connection. Is this the only connection? No. Is it very likely a compelling one? Yes. But it is a multifaceted explanation, and this is one facet, is the amount of sugar. I have no idea where this graph came from. I got this graph a long time ago. Like, oh, that's interesting. From 1820, from 1822 to 2005, how much sugar people are eating. Okay, but we all know that the amount of sugar consumption is going up. But how much sugar do we actually have in our entire body? 4 grams. You have a teaspoon, right, in your entire body. All of your blood. You have 5 liters of blood. And Nathaniel's 6'6". He's gonna have more. It depends on how big you are. Depends how much blood you have. It depends on your body mass or whatever. But between 4 and 5 grams, 4.3, 4.4, 4.5, something like grams of glucose. That's it. That's all you have. How much sugar is in a Coke?
40 grams.
Like 40, 10 times the amount you have in your entire circulation. 10 times. What the hell do you do with it when you swallow that? What the hell? What are you supposed to do with all of that? Historically, we did not have access to things like that. Occasionally, whatever, you get stung a few times for a bite of honey. Occasionally, you can find a berry. Okay, whatever. Historically, if you're going to go through anthropological explanations of diet, it was nothing like today. And our ability to tolerate sugar is hilariously bad. And so we have a lot of stored energy substrates, right? The glucose here, it's at 4.3 grams. Who cares? It's around 4 or 5 grams of glucose. That's all we have. Now, glycogen, you might have a pound of that. Here it says you have a pound. You have about 350 grams or so in your skeletal muscle. And you have about 100 grams in your liver. Ballpark figures, super ballpark for that stuff. Just call it a pound, 454 grams of a pound. So you do store some glycogen. You can run out of glycogen in one marathon. You've seen it. Watch people cross the marathon. Watch them cross the finish line. They're all loopy. They have no idea what their name is. They have no idea they're in a race anymore. Carbs are low. You can run out of that stuff in a hurry. You're not going to run out of fat, but you can run out of carbs in a hurry. So you eat sugar, something more than like 5 grams, something more than double the amount that you have in your bloodstream, and your blood sugar will go up. Right? Remember, 100. If you hit 100 on a fasted, that's pre-diabetes. Hit 126, now we're diabetic. But you would need to do this multiple times because lots of it just gets stressed out. You're going to get cortisol response. Cortisol is going to mobilize a bunch of glucose. Same thing with epi, norepi, epinephrine, norepinephrine, or adrenaline and noradrenaline. These are also going to mobilize glucose. So if you're stressed out, if you're sleeping poorly, stuff like this, your fasted values are going to be elevated. Those aren't real fasted values. That's getting you ready for battle. Sort of Stone Age stresses that still reside within us. So we eat sugar, and our pancreas has to kick out insulin because you can't just leave the sugar in there forever. You can't say, well, just get this up to like 20,000. That's not, vampires would love it because they would have something sweet to drink, but that's not how a body works. So what does insulin do? Again, we put carbs in our mouths, right? Our collective mouth. As a class, we have one mouth, and we put carbs in it, and our blood sugar goes up a lot higher than it ordinarily is. The pancreas notices. Beta cells in the pancreas, alpha cells don't have as many of those. Those release glucagon, which is mobilized carb. Beta cells release insulin. Insulin binds to an insulin receptor, right? Cell surface receptor. So this is like the cell wall right here, right? Outside of the cell, extracellular space. Inside of the cell, in here. So insulin binds to a cell surface receptor, and that triggers a cell signaling cascade. We'll get all into these when we're doing mTOR. I don't like AKT, PKB, there's a better name for that. So insulin receptor substrate, that's just a little protein right here. We're going to turn on a thing called PI3K, which isn't on here. Okay, phosphatidylinositol 3 kinase that converts PIT2 to PIT3. That permits PDK to activate PKB, protein kinase B, through AS160. We're going to mobilize our GLUT4. GLUT4 brings glucose into the cell. So insulin brings glucose from our blood into the cell through PKB signaling. Just remember protein kinase B. At this stage, all you need to know, unless you've had me before, but still the accountability is the same. All you need to know, the protein kinase B, PKB signaling. Sometimes I might call it PI3K signaling or PKB signaling. Insulin binds to its receptor. PI3K initiates this huge part of this cascade. P10 does the opposite conversion, which would be great as like a cancer drug. We'll talk about that in a minute. PKB is responsible for the mobilization in this cascade, facilitating the mobilization of GLUT4, translocation of GLUT4 so that glucose can enter the cell. So insulin brings carbs from the blood into the cell. So that's good. We need carbs in the cell. They're useless in the blood. They're harmful and useless in the blood. There's more to it though. Once you bring carbs into the cell, do you consume them? Do you burn them? Do you do glycolysis? What do you do with those carbs? Once the carbs are inside, what do you actually do with them? You turn on glycogen synthase and make glycogen out of it. So you store them. Insulin is about storage. It's about storage of fat too. Something else that insulin will do through PI3K and PKB, through that same signaling cascade, is activate an enzyme called PDE, phosphodiesterase. Once you do that, you break down cyclic AMP, and you need cyclic AMP to mobilize fat. So insulin stops fat metabolism. You cannot mobilize fat in the presence of insulin. And it calls sugar into the cell. GLUT4 translocation. Let's bring sugar into the cell. And then let's make complex carbs out of it. Let's make glycogen out of that sugar. That's what insulin does. Now, diabetes, there's a type 1 and a type 2, right? Type 1 is very different. This is the symbol for diabetes. If you see this big blue O, that is a symbol for diabetes. So diabetes is, for type 2, is insensitivity of those receptors. Type 1 is your beta cells aren't doing their job. The beta cells in the pancreas, those aren't doing their job. Type 2 is the one we talk about. Most people, 90, 95%, I don't know, you can look up the number. Most people who have diabetes, what they're talking about is type 2 diabetes. And is it like the oatmeal guy that said diabetes? Is that like the oatmeal guy? Ray Wilson from The Office, I thought said best.
Yes, I am. So technically, I am your boss, kid president.
Is it pronounced diabetes or diabetes?
It's actually pronounced diabetes.
Okay, so that's Dwight Schrute from The Office, diabetes. But there's diabetes insipidus, diabetes insipidus. That's vasopressin stuff. Totally different, totally unrelated, has nothing to do with the diabetes you think about. Diabetes mellitus, diabetes mellitus. This one has the type 1, type 2. Again, dysfunction of the pancreas, the beta cells in the pancreas, that's type 1. We're not talking about that. We're talking about type 2, which is the really prevalent version, which is dysfunction of the insulin receptors. And you just get numb, you get immune, you get inoculated, you get however you want to phrase it, you become insensitive. The receptors, when they just hear insulin knocking all the time, just knock, knock, knock all the time, insulin, and you just stop answering the door. All right, those receptors start to develop resistance, right? Lots of complications. That's not really what we're going to talk about, the complications, but neuropathies, retinopathies in your eye, all these pathies, higher risk of cardiovascular problems, metabolic syndrome. commonly follows. It doesn't have to, but metabolic syndrome commonly follows. And I wish you could see his belly button. It's a little bit too light, but when you see somebody who's like shirt is just so stretched out, but like it's a miracle the button is still in there. There's like his belly button. But so metabolic syndrome is this weird condition where you get a constellation of the presentation of symptoms. There's this big constellation of problems. This is a Mayo Clinic website. The waist. So you need 3 of these 5, and you'll be classified as having, quote, metabolic syndrome. Large waist, right? Just abdominal obesity. Not like your hips are big or your BMI or whatever, but your waist, right? Your waist is big. And remember in the ACSM thing when I said it's 88 for women, it's 102 for men. It's pretty much the same thing. Where for that's centimeters, not inches. But it's 89 centimeters for women and 40 inches, 102 centimeters for men. So the same thing as those cutoffs in ACSM about waist circumference, but nothing about BMI there. The triglycerides, really high triglycerides, 150 and up. I'm not going to hold you accountable to these exact numbers, but just know the 5 thematic conditions. HDL goes down, right? Triglycerides go up, HDL goes down, waist circumference expands, blood pressure goes up, and elevated blood sugar. So essentially, diabetes or pre-diabetes. The elevated fasting blood sugar at 100. Remember the ACSM guidelines, 100, between 100 and 126 in that little space right there is considered a risk factor. So all of these just travel together. It's like a quintet. The little quintet, they travel together. Now, once a body has that quintet inside of it, or is characterized by it, like lots of complications, mostly cardiovascular, but the risks that are going to bring it about, insulin resistance, those cell surface receptors, insulin resistance, the argument is like, is this a cause or a consequence? And likely a cause. My take, which isn't law, but my take is it's insulin resistance is pretty culpable to everything that follows. You can reasonably blame insulin resistance on a lot of complications that trail it, that accompany it. But if you're having poor sleep and you're sedentary and you're really stressed out, that's also going to have a predictive effect. Visceral storage of fat, all of these things just go together. But if it's in the family tree, you got to be extra cautious. Now, I pulled this off of Wikipedia a long time ago. It was talking about metabolic syndrome, and I just thought it was so funny that I saved it, and it'll make a comeback every once in a while on my slide. So this is from Wikipedia. It's from 2015, and there's no way it still says this. The central role of the cannabinoid system in the development of metabolic syndrome is indisputable. Whenever anybody says indisputable, you can distrust everything that came before it and after. Endocannabinoid overproduction and disbalance may exacerbate cortical limbic reward system dysfunction and contribute to executive dysfunction, e.g. impaired delay discounting, perpetuating unhealthy behaviors. The brain is crucial in development of metabolic syndrome, modulating peripheral carbohydrate and lipid metabolism, citation needed. Okay. And so this is what that's saying, right? The role of blah, blah, blah is indisputable. Gibberish, 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 citation needed. So sometimes you just have to be cautious in where the information is coming from. Go to CDC, right? Go to Mayo Clinic, go to a reputable journal that's indexed by PubMed. Get something real for all of these things. Now, for diabetes, drugs are a possible treatment, right? You can use drugs, lots of different drugs. You can release more insulin. You can just take insulin, or you can cause let's just go to an endocrinologist and ask them what they prescribe for type 2 diabetes. Often, it's just more insulin. They're essentially immune. So just like if one beer doesn't do the trick, what do? 30, yeah. 30 beers. And so that'll work too with insulin. Now, chronically, that's horrible. Chronically, that's a horrible thing to do with insulin, right? Is just to increase the dose, increase the dose, increase the dose, because the consequences are so severe. But you can make the pancreas release more insulin. You don't need to know the specific drugs or anything. You can inhibit the production of glucose, gluconeogenesis, generation of glucose from non-carb sources, gluconeogenesis. You can inhibit that by the liver. So there's a classification of drugs that's going to help inhibit the production of additional glucose. You can inhibit the breakdown of complex carbs, sort of slow the conversion into sugar, and just eat all of the carbs you want, but you know, let's take some drugs to try to. You can also do like, you know, something to prevent their absorption, whatever. Increase the sensitivity of the receptors to insulin. You know, that's a possibility. There's a lot of angles that the pharmaceutical industry has come up with to help resolve diabetes. But like, what did Herodotus say? And everyone else, right? What did Confucius say? Right? What did Sushruta say in India before him? What did Hippocrates say? You just go back into history and we have this, right? Here's Herodotus. This is the theory of Herodotus. Nutrition and physical activity, when they're unbalanced, right, we get disease. Diabetes, chronic version of disease. Now it depends how chronic it is. Is this sort of newly onset? This is exercise and nutrition can essentially cure it. But an imbalance between nutrition and physical activity. What does physical activity do? Well, if you're chopping down trees at 51 axe blows a minute, that's about 17 and a half times your resting metabolism. About 17 and a half times. This is from Barbara Ainsworth's compendium. You know, and this one, here's our lumberjack. This one is 8 times your resting metabolism. You're lying in bed. 8 times the amount of ATP consumption, the amount of oxygen consumption. If you're running, training, pushing a wheelchair or a baby carrier, so whatever, you're like running behind this person or something. 8 times your resting metabolism. You're consuming a lot of calories there. Now let's go back to what insulin does. So remember, if you take insulin, if you eat carbohydrates, you get an insulin response, binds to its receptor, we mobilize GLUT4 downstream from PI3K, PKB signaling. We mobilize GLUT4, but also once those carbs are inside of the cell, we turn on glycogen synthase. Glycogen synthase takes those carbs and makes complex carbs out of it, makes glycogen out of it. Now, if you exercise, if you're doing aerobic exercise, chopping down your tree or whatever, pushing the, like person in the wheelchair or shopping cart or whatever it is you're doing, we're going to activate AMPK, adenosine monophosphate activated protein kinase, AMPK. The way that one works is everyone knows Atp hydrolysis, right? You have that, you have ATP, adenosine triphosphate. You chop off one phosphate. Now you have ADP. And a phosphate and a hydrogen ion. Yeah, so the phosphate that goes floating off, whatever, you plug it up with an O and an H, but you have to put water into it. And so there's your O and the H that plugs up the phosphate, and other hydrogen ion goes floating off. But now we have ADP. So we had ATP. We chopped off one phosphate, now we have ADP. During exercise, if you're exercising at 8-fold, 17 and a half fold, your resting metabolism, you're generating a lot of ADP. So what you do is you take 2 ADPs, so ADP plus ADP, and there's an enzyme called adenylyl kinase. And you make 1 ATP and 1 AMP out of it. You just take a phosphate from one and give it to the other. So you get ATP back. You can keep going, but you're accumulating AMP. AMP binds to AMPK, adenosine monophosphate activated, AMP activated protein kinase, and AMPK does insulin's job way better than insulin. Way better than insulin. So during aerobic exercise, during endurance-y, long duration exercise, you're going to activate AMPK, AMP activated protein kinase. AMPK is going to mobilize GLUT4, bring sugar into the cell. And then at the same time, it's going to inhibit glycogen synthase. So you don't make carbohydrates out of it. So glycogen synthase is shut off so that glucose does not get shoved into glycogen storage, and it turns on glycolysis through both hexokinase and phosphofructokinase. The first step if you're going from glucose is hexokinase. And then PFK, phosphofructokinase, is the third step, I guess, if you're going from glucose. If you go from glycogen, glycolysis is a little bit different. You skip hexokinase. But what AMPK does, it mobilizes GLUT4, so it brings sugar into the cell. It shuts off the ability to convert that sugar into glycogen, and it turns on glycolysis, so you immediately consume it. If you have elevated blood sugar, or at risk of diabetes, or have some sort of glucose regulation problem, the single best thing you can do is turn on your AMPK. How do you do that? Exercise is the best way. Here's another, metformin. What metformin does, one of its effects, metformin does a lot of things, but one of its effects though is an AMP deaminase inhibitor. So remember, we have ATP, we chop it up, ATP hydrolysis, we get ADP. We keep doing that, we get a lot of ADP. We use adenylyl kinase to take two ADPs, make one ATP and one AMP out of it. Now, the AMP, you dispose of it with AMP deaminase. During exercise, you don't dispose of it fast enough, it accumulates, it accumulates, it accumulates, it accumulates, activates AMPK, AMPK does its duty. Now, metformin, if it's blocking AMP deaminase takes that AMP and converts it into IMP, inosine monophosphate, and ammonia. You don't do that conversion in the presence of metformin. Instead, you accumulate AMP, which turns on AMPK. So metformin, one of its effects is to turn on AMPK. So that works pretty well. It's well prescribed, and it does have other functions. But as soon as you see AMPK activity dysregulation, if AMPK is not doing what it's supposed to, if AMPK is not functioning as it should, you're going to get insulin resistance. You're going to get a lot of consequent problems. AMPK is so critical, and the most reliable way to turn it on is exercise. So for both of these two articles are both downloadable at that clinicalphys.com. If you just scroll down and say lecture 5 articles or whatever, and click on that, there's a zip file. Both of these are there, but it's talking about exercise and diabetes and some of these interactions. But the best mechanism is you're going to improve insulin sensitivity, which is the problem in type 2 diabetes, and AMPK is central to that mechanism. Last slide, because we're nearly out of time, but for cancer. Exercise and cancer is a huge topic. Our own lab, a few years ago, something like that, the national president of ACSM, Katie Schmitz, she sponsored 6 of our abstracts for ACSM. She's a cancer epidemiologist, I mean, world known, huge researcher. She's national president of ACSM. So she sponsored 6 of ours on cancer and exercise. It is a huge topic. Now, central to that, AMPK. We again have AMPK. And we have, there's a lot of suppression of cancer over here. When we're looking at autophagy and the ubiquitin proteasome system, the lysosome and the ubiquitin proteasome system, we'll talk about both of these later in the semester. We have one lecture dedicated to atrophy and to protein degradation, and we'll talk about both of these. We're going to FOXO and WOLF1. This is cancer refs. This is monitoring of cancer. Now, the opposite of that, the effect of insulin activating PKB, PI3K, PKB, you're shutting off this stuff. So insulin turns this off. AMPK turns this on. In the presence of cancer, you got to be exercising. And so these two articles are also in the link, and it talks a lot more about, actually Katie's on one of these right here, this is one of hers. So this is the epidemiological paper, and then this one is mechanisms. There's a lot of mechanisms that are described. That's all.
Is there a dog food version for humans? All-encompassing meal?
Like some like substrate that just has everything. But I think that's the whole point of like the meal replacement, those MREs or whatever. But I think that has like, there's macaroni in here, and there's, I think they just put a bunch of stuff. I don't know what the food would be that is. Just a bite of this, and you are set.
Eat that 3 meals a day. Like, I don't know.
It'd be like the Steve Jobs food. These are more like the exact same outfit. I mean, it's trying to decide. The time to decide an outfit